misinformation. Kind of lots of people that I've talked to about it, it's like, oh no, that causes this or that, and there's all these concerns about it. And so we'll kind of go into that, how that even came about, and why it might actually be quite a bit more beneficial than risky than people think. So just a little bit about me. This is my wife, Savannah, of 8 years. This is my 3-year-old boy, Aiden, and now he's 1.5. And now he's not bald, so it looks very different. But 1.5-year-old Cohen, not pictured as baby girl, coming in September. And then we have Jovi, our family Roomba for toddler food that's thrown, any misplaced socks, and their doorbell. So, which I would highly recommend. If you have people in your house that throw rice and you're picking up rice, get a Jovi Roomba. So our agenda: female hormones. We'll talk about the symptoms of menopause. We'll talk about hormone replacement therapy, its risks and benefits, who is a candidate, and different treatment options. So the hormone cycle, this is obviously kind of the pre-menopausal cycle. So during your pre-menopause, hormones cycle quite a bit. And you have a period, and then your estrogen starts increasing and then fills your uterine lining. And then you have an LH surge, which helps with ovulation. And the egg comes out, and the progesterone kind of maintains that uterine lining, prepares everything for fertilization. And then, more often than not, probably it doesn't happen, and it gets angry and tears down the walls, right? And then you have your period again. But
I want to interrupt one thing.
Yeah.
It says testosterone is not on the graph. Where would testosterone be? Because I found this fascinating.
Where would testosterone be?
Yeah.
As far as,
So what I'm getting at is that we have a lot more testosterone than we have of any of these other hormones, which I did not understand. So if it's not on the graph, because it would be way up there.
Gotcha. Yeah.
That's what I was getting at. Sorry.
Which is interesting for people to understand. It's just the ratio is way different in the man.
Right.
But yeah, all that to say, estrogen is not just for reproduction. It actually, there's receptors on every single cell of our body, right, for estrogen. It impacts the brain, the liver, the bones, our skin, our heart. So it's not just for reproduction. Even though we're kind of cycling like this, the low points of estrogen, as you can see with pre-menopause, when you go down, when you have your menstrual period and you have that low point, you're still having higher amounts than in post-menopause, right? So, and then ultimately you look at the area under the curve, like how much estrogen you have total, over time. You have a lot, and then you go into perimenopause when you have more irregular periods, you start having some of those symptoms that we will talk about. And things start fluctuating, and periods get more irregular, and then eventually your estrogen declines to a very low level. And so some people might say, well, what's the issue with this, right? That's just natural, it's just the way it is. Why are we doing anything about it? But I think what's not natural is living till 80, 90, right? So the age of menopause was kind of similar to the age of death for a long time on average. And basically the last 100 years, our life expectancy has been increasing. So women are living hypoestrogenic and very low estrogen for a third of their life. And so that's a significant reason to want to look into this more. And just knowing how important estrogen is. So who knows some of the symptoms of menopause? Anyone know anybody that has had these?
Let's see, hot flashes, dry mouth, dry skin, stiffness. stiffness in joints. Anyone chime in at any time?
Okay, I had super dry eyes even.
Dry eyes.
Yep. Plantar
Brain
fasciitis.
fog?
Yep.
Yep. Plantar fasciitis, yeah.
Night sweats.
Night sweats?
Social anxiety.
Social anxiety, yeah, definitely.
Brain fog.
Brain fog.
Heart palpitations.
Okay.
I can keep going.
Did I give you the list beforehand?
No, I'm just telling you about a day in my life.
Yeah. So yeah, vasomotor. So this is vasovessel motor muscle. So the muscles of your blood vessels are kind of dysregulated. Estrogen helps regulate those things, so you have some thermal dysregulation. Not necessarily fully understood, but we all know what it is, right? We get these hot flashes, night sweats, you get heart palpitations, and sleep disturbances, and part of that is from these hot flashes, you're not able to sleep, right? And night sweats. Genitourinary, so this is a big one. So the vaginal area, vaginal canal shortens, tightens, atrophies. So you have increased risk of UTIs, increased bleeding, more pain with intercourse. Urinary incontinence can all be an issue. Sexual low libido, difficulty with orgasm, pain during intercourse. Musculoskeletal, you get joint pain, people can get frozen shoulders, different tendon pains, lots of muscle pain, body aches, things like that can be increased. I mentioned brain fog, loss of memory, difficulty concentrating. We mentioned some mental health, depression, anxiety, mood swings. Thinning of the hair, sweating of the hands and feet, dry mouth and eyes. We mentioned weight gain around the abdomen, increases, headaches, migraines, loss of energy, increase in cholesterol, increase in cardiovascular risk. Those things can all happen with menopause. Okay, so hormone replacement therapy. This was a big thing in the end of the 20th century, right? So in the 1990s, 40% of eligible women were taking HRT. Yeah, by the way, we have a bunch of food and no one got it. So maybe someone should. Otherwise, that's a lot of banana bread for me to eat. Maybe on the way out, at least. So this was largely validated by like 65 epidemiological and observational studies. So lots of studies showed, okay, there's decrease in mortality, decrease in heart disease, and it's really helping these symptoms, right? So it was kind of looked at as this is a great thing, but we don't have that randomized controlled trial. And so that was something that, that was always that question mark, right? We don't have a randomized controlled trial. Maybe the people that are going into the clinic to get the hormones are also the people that are taking care of themselves, and therefore, they have less of these symptoms and less of these risks. So that was the question, and so then in comes the Women's Health Initiative, probably I'll call it the WHI. It's a big randomized controlled trial, $1 billion trial, and they separated women into two groups. So 16,000 women with a uterus divided into placebo and an estrogen and progesterone group, and 10,000 women without a uterus divided into the placebo group and an estrogen therapy group. And so maybe you guys all know this, but women with a uterus, you need to have the progesterone as well. Because estrogen, it stimulates the growth of the uterine lining, and anytime cells are dividing more and more and more, there's an increased risk of cancer. So the progesterone kind of stabilizes that uterine lining. And so that's why we have to divide it out. But there's not really enough benefit of progesterone to do it in women without a uterus. So that's why we do both of those. And in 2002, there was a press conference, and kind of the leaders of the study halted the study and brought in the New York Times or whatever, and they're like, okay, there's a 26% increase of breast cancer, right? And this is before the scientists and it wasn't peer reviewed and things like that, right? So it was just kind of halted and quickly done. And so the consequences of that, women stopped taking HRT. Today, only about 4% of eligible women are on HRT. Less than 6% of physicians get even 1 hour of training in HRT. So it's not really even talked about. And it is becoming more so now, unfortunately. but for a while it has been very minimal. And so we're not treating the symptoms, we're treating the symptoms, not the root cause. So women are prescribed antidepressants, sleep medications, are told, pat it on the head, you'll get over it. So, but there's some flaws with the study and kind of with the conclusions from that study. So we'll look into that. So it's important to understand absolute risk and relative risk. So the 26% was a relative risk. That's comparing the two groups as opposed to the absolute risk of taking the medication. So the absolute risk was increased by 0.08%, right? So if we look at it, there was, in the placebo group, there was 4 in 1,000 women develop breast cancer. So a pretty small amount, right, of breast cancer, but 4 in 1,000. And in the estrogen and progesterone group, there was 5 in 1,000. So they stopped the world to say, hey, there's a 26% increase, but it was a 1 in 1,000 increase, less than a 1 in 1,000 increase. So it's really important to understand, and obviously the media always uses relative risk. So whenever you see like a risk and you see a percentage, no, it's probably relative risk because that's going to catch your eye, right?
Yeah. It took them 20 years to correct this. It's that simple.
Yeah.
It's really weird. When you read about it, it's so strange.
Yeah. I mean, one might feel, if you weren't inclined to conspiracies, you could probably, delve into that. But who knows? I mean, this was the $1 billion trial to end all trials, right? So there's they have a lot of backing and a lot of power behind them, right? Yeah, I'm not sure. So the other aspect of this is the increase in breast cancer incidence in the HRT group compared to the placebo group almost reached statistical significance. So it wasn't even statistically significant. Usually that's kind of how they benchmark. Is this, legit, or maybe there's just other variables, we're not sure. And instead of saying that, they said 26% increase, whatever. The other aspect is that the group on estrogen alone, remember we had estrogen and progesterone, and estrogen alone actually had a relative 21% decrease in breast cancer. So again, they didn't stop the world and say, hey, everyone without a uterus should be on estrogen because you're going to decrease risk of breast cancer by about the same that you increase it on the progesterone. So even though both of them, again, are relatively very small absolute risk changes. The other thing is the placebo group had an unusually low rate of breast cancer. So whenever you do a randomized trial, you're going to randomize two groups, right? So you expect it to be about 50-50, but sometimes it's like a 40-60, right? And you never know if it's perfectly randomized. And so there's an unusually kind of an unexpectedly low rate of breast cancer in the placebo group. And that is possibly because more of them, there's a higher than expected rate of people that had been on HRT prior to this, right? So the potential was the HRT protective, and that's why they had a lower than expected rate of breast cancer. And so when you exclude the people that were on HRT prior to the study, there was no difference in breast cancer. And then the other issue is that the age of participants were not the ideal age. The average age was 63. It was about 40% smokers, higher than that, obese. I mean, these were not necessarily the ideal patients for HRT either. And we know, pretty much without a doubt that it is most beneficial if started within 10 years of menopause. And there's nuance to that, but this was not the ideal group to study, ultimately. So absolute risk and benefits from this is looking at the WHI. So this is looking at specifically women aged 50 to 59. So this is that absolute risk that we're talking about. And basically the top is estrogen, and then this is estrogen and progesterone. And the other aspect that I would say is the progesterone that they use was a synthetic progesterone, and there's a lot of evidence that that is much more risky than the progesterone that we use today, which is mechanized bioidentical progesterone. So that's another aspect. But ultimately, kind of looking at pink, good, red, bad, right? As far as the risk and benefits found in this trial. So we're looking at diabetes, decreased risk of diabetes, decreased risk of fractures, decreased risk of all cancer types, decreased risk of colorectal cancer, decreased risk of all cancer deaths, all-cause mortality. So across the board on both sides, there's kind of that decreased risk, right? So ultimately, just visually, we see, okay, there's more pink than red. There's that, right? And then, like I said, specifically with this breast cancer, we kind of talked about that, and then also with it being synthetic progesterone, that's part of it. And then the rest of the reds are kind of, so it's deep vein thrombosis, pulmonary embolus, stroke. These are kind of things that are more like, that have to do with the coagulation of the blood. So an estrogen, oral estrogen can increase our clotting factors. But another important thing to think about here, one, again, pretty small risk, right? Two is that we now generally use transdermal estrogen. Transdermal estrogen goes right into the bloodstream as opposed to going into your digestive system through the liver. So it's not affecting clotting as much. And there's been studies that show that there's not really an increased risk with transdermal estrogen of blood clots. So kind of if we were to say, okay, let's do transdermal estrogen and bioidentical progesterone, probably we're seeing all pinks, but we're not going to do another $1 billion study because we already did it, right? So the risk that you may have heard that we kind of talked about, the WHI estimated a 4.7 in 1,000 increased risk of estrogen and the synthetic progesterone, and a 1.3 in 1,000 with unopposed oral estrogen. But that risk has not been kind of played out with transdermal estrogen and micronized progesterone. Cardiovascular risk, there is a significant reduction in risk in ages 50 to 59. There is a slight increased risk with over the age of 60, taking both estrogen and MPA, but not just estrogen. And then breast cancer, as we discussed, probably pretty minimal, if any. Probably, if we were to say that 0.08% increase is true, probably less than 2 glasses of wine a day, less than obesity, less than there's lots of different lifestyle things that it's going to be less than. Put it in perspective.
What's the difference over 60?
So over 60, and we'll talk about that. It's not. Okay. Yeah. Okay, we'll get there. So benefits of HRT, this is kind of just another figure of all those symptoms that you guys outlined so well. It's going to relieve a lot of these symptoms. Maybe not completely, maybe not all of them, but most of them. So vasomotor symptoms. Now, again, this is something that oftentimes might be poo-pooed a little bit, like, oh, you're having a hot flash, laugh it off, whatever. But it's a significant decrease in your quality of life. So it's highly prevalent. 75% of women get these hot flashes. The average duration is 7 to 10 years. That's average. So some experience this for the rest of your lives. There's women that are very old and still experiencing hot flashes, and it is associated with a lower quality of life. So not something just to wave away, right? Because if there's differences in mood, in ability to function at work, in ability to function in family and social, there's so many things that this can affect, and they can all impact your health. Genitourinary syndrome of menopause is kind of how they talk about the vulvovaginal atrophy, the atrophy of the tissue that leads to the increased UTIs and intercourse. One thing about this is that really you can treat it with topical estrogen. So you can do the estrogen creams, which really has been shown to decrease the rate of UTIs and urosepsis, death from urosepsis. And again, people might say, oh, it's a bladder infection. Well, there's women in the hospital all the time with urosepsis, a urinary tract infection that went systemic, and there's women dying from this, and we know that it can be significantly reduced with vaginal estrogen cream. And I think if this is something that you're struggling with, then probably, you can just use the vaginal estrogen, but you can also, I think, as we'll talk about more, using both is a good idea. Body composition. So there is greater visceral fat. Visceral fat is fat around your organs, and there's a loss of lean mass and an increase in total fat mass in menopause. So what happens is the fat, that we see oftentimes, the subcutaneous fat, and that's like butts and thighs, right? It's usually pretty metabolically neutral. It's actually, oftentimes not that detrimental to metabolic health. But the visceral fat around the organs, is, and it can decrease the function of your organs. And what happens is, when you have visceral fat, that means that your subcutaneous fat is not accepting as much energy, kind of the triglycerides, to store them. So they float around and they fall into your around your organs here. And they also will go into your muscles and they'll go into your cells. And so people have intracellular lipids that, things aren't functioning as well. And we can talk a little bit more about with that with insulin resistance, but it creates a significant issue for your overall health and it's just function. So studies, so far, they can't do very long studies, right? Those are really hard. But they have shown a significant difference, a decrease in visceral fat after 6 months even, between HRT and control groups.
How do I know if this is visceral fat or subcutaneous fat?
Yeah. So one thing that I usually would recommend is a DEXA scan. It's probably one of the best ways to know. And we can look at overall metabolic health as well to kind of understand the likelihood of it. Of course, well, the best way is like a full body MRI, but we're probably not going to do that. Yeah, exactly. So a DEXA scan is a reasonable option to kind of understand the difference between visceral and subcutaneous fat. I think it's important because probably they estimate about 80% of overweight obese people are actually relatively metabolically healthy, whereas about 40% of normal BMI people are metabolically unhealthy. And it's hard to really know that unless you're looking at your body composition, looking at your metabolic health, your blood work, and stuff like that.
Just for reference, I did a DEXA scan and it was 149, very reasonable.
Yeah.
Took 15 minutes.
Yeah, it's super easy. It's a very low dose CT. I mean, there's no concern about radiation with it. That's all it is. And it's pretty cheap, and it can be helpful to let's monitor it. Let's do it, maybe every couple of years and see kind of where we're trending, making sure we're not, increasing our visceral fat. And then also, obviously, we'll look at bone density and muscle mass and things like that are also really important. So potential benefits with insulin resistance. So insulin resistance is a big topic, and I don't know how much you guys know about it. It is more and more in the media, I feel like, but it's not necessarily in modern medicine as much because there's not specific treatments for it. Can't make as much money, I guess, I don't know. But I think it is one of the big things that is kind of one of our big issues. You talk about like, okay, why are we getting less and less healthy as a nation, right? There's all these more and more chronic disease, and I think insulin resistance is one of those things. And it's a major aspect of metabolic health. Metabolic health is your ability to utilize fuel for energy. And insulin resistance is kind of the aspect of carbohydrate metabolism, right? And I think a big issue is for thousands of years we're having whole foods, we're having whole carbohydrates, right? We're having potatoes and we're having whole grains and things like that. And now we have 70% of our grocery stores are highly processed carbohydrates, and they've added sugars and they strip the fiber away, and we have constant availability, and our bodies just haven't adapted to that, and that's like the last 50 years, right? Ultimately, it's how well your body can utilize carbohydrate. The more and more insulin resistant you are, the harder it is to lose fat, the more likely it is that your fat will not respond to the insulin, and then your fat will kind of deposit in organs, like where it is that your muscles won't be able to take up the energy they need, because insulin is what drives the glucose into the cells. Increase they call Alzheimer's type 3 diabetes, because it's what it is. It's not diabetes, it's insulin resistance, where your brain isn't able to take up the glucose it needs for energy, so it has to decide, okay, am I gonna make this memory, or am I going to walk up the stairs, right? And so it's just there's a scarcity of energy despite an overabundance of energy, right? Because our body is adapted to start saying, okay, we don't need any more, so we're becoming more and more resistant, and that happens in all our cells. So my wife told me not to get too much of a tangent in that. Yeah, I have a lot to say about it, but all that to say is estrogen can play a role, potentially. There's more research that needs to be done. We know that it decreases diabetes, which is kind of on that spectrum. It's on the end of the spectrum of insulin resistance. And so there's a lot of evidence that this likely can decrease your insulin resistance. I mean, knowing that it decreases your visceral fat, knowing that it decreases risk of diabetes, it's going to decrease your insulin resistance. Osteoporosis, this is one of the biggest ones, I would say. And if we think about hormone replacement therapy, what's FDA approved? It's FDA approved for vasomotor symptoms. It's FDA approved for the genital urinary syndrome of menopause, and FDA approved for prevention of osteoporosis. So prevention of osteoporosis, every woman's at risk of osteoporosis, right? So that's kind of like a green light to me in some ways. Not that you can't do things off label, but what happens is, women, when you go through menopause, your estrogen drops dramatically, and therefore, as you see, the bone density drops dramatically. And compared to men, where it's kind of more of a slow decline. So estrogen plays a huge role in preventing bone resorption and increasing bone density. So that's why it's such an issue for women. And big issue with osteoporosis is the risk of fracture, right? And so it says 1 in 3 adults aged 65 and older dies within 12 months of a hip fracture, which is kind of a crazy number, right? But you think about it, you break your hip, you can't do what you love, you can't, you kind of lose lots of function, and there's things kind of spiral, right? So it's really important to prevent hip fracture, obviously any fracture. So HRT has been shown to prevent bone loss and reduce the risk of fracture by 20 to 40%. And that's, again, most of these things, greatest benefit if we do it within 10 years of menopause. There is, what I want to say is bone loss will resume once you stop HRT. There's not a rebound, but you probably will eventually get back to where you would be. So it's something that usually you'd want to take long-term for the osteoporosis benefit at least. Coronary artery disease, so everyone's scared about the breast cancer thing, but there is a significant reduction in coronary artery disease, and that's the leading cause of killer of women. So it's greater than the next 16 causes of death combined. So it's a significant issue, right? And HRT has been shown to significantly decrease risk of cardiovascular disease as well. Neurodegenerative disease, women are twice as likely to develop Alzheimer's than men, possibly related to the estrogen loss. The loss of estrogen can increase neuroinflammation. There was a trial that showed decreased plaque buildup in those taking estrogen. It's hard to do the long-term trial again, so it's something that we need more research to know more. But potentially there's benefit, and it doesn't look like there's a risk at least. Colon cancer. So again, the WHI found a 30% reduction in colon cancer. That's the relative risk, right? Which is as prevalent as in women. It's about half as prevalent, but they didn't mention this on their news flash. Other studies have shown up to a 63% risk reduction in colon cancer. caveat to that is mainly found with oral estrogen. It's found in some studies of transdermal estrogen, but mainly oral estrogen. Improved mood. There's studies that show improved, increasing subjective positive emotions, decreasing negative emotions, and how much of that is, well, I'm not having hot flashes and night sweats and I'm sleeping better, But so whether it's directly causal or it's improving those other symptoms, either way, I mean, it's a good thing, right? There can potentially be like a period of increase. Some people can have initially a period of increased mood swings. So usually that can be helped if you titrate up slowly. But those do usually go away. Improved sleep. So there is a decreased sleep quality, as we discussed, in perimenopausal and postmenopausal women. Estrogen replacement improves sleep quality. It reduces vasomotor symptoms and reduces nocturnal movements. That's been seen in studies. And then progesterone has also been shown to induce sleep and decrease sleep apnea. So maybe one benefit to, taking the progesterone, but overall, like I said, if you don't have a uterus, maybe you don't need it, probably. Hair changes, there is an increase in female pattern hair loss in menopause and potentially some rogue hairs on the chin. You kind of have that different balance of testosterone to estrogen, so the ratio increases that androgenicity, that increased use what testosterone might do. And so estrogen kind of lengthens the growth phase of hair follicles, and progesterone can decrease the conversion of testosterone to dihydrotestosterone, which is what leads to hair loss, and that's what God said, but it can happen in women too. So, and then this is obviously a really busy slide, but I think it's just helpful to see. I'm looking at like the meta-analysis. So like, let's take a bunch of studies and look at them. And look, coronary artery disease decreased 48% with HRT. Obviously, this is a relative risk. And all-cause mortality decreased 30%. So that's a pretty good news right there. And pretty much all of these are decreasing, the risk. So who's a candidate? And so this is kind of where I'll hopefully answer your question. It's largely, stated that it's ideal to start less than 60 and less than 10 years since menopause. Again, that's largely based on the WHI, the use of oral estrogen and synthetic progesterone because of the increased risk of heart disease. And the theory behind it is once you already have more plaque buildup, there is potentially, smaller blood vessels, and there's potentially a higher risk of, clots forming and plaque, inflammation and things like that when you start estrogen. But if you're kind of on the earlier side, it actually has shown significant benefit in, vasodilating and decreasing inflammation in the blood vessels. And I would say as far as this, like less than 60, less than 10, definitely can be personalized and nuanced. If someone has, we know that you're cardiovascularly really healthy, and we can test that. We can look at your, blood pressure and cholesterol, and you smoke, and we can get a coronary artery calcium score and all these things. And maybe it's worth it, right, to start. And my mom started at 65. This is way before me knowing any of this, but and she's cardiovascularly healthy, but she still couldn't sleep and was still having hot flashes, and now she's a lot better. So, but fortunately, she didn't have the risk of heart disease at that point. So, treatment options. We'll talk about the side effects. Vaginal bleeding is the most common. So it's about 80%. Most of your body has adjusted to it by about 6 to 12 months. So usually that resolves. Breast tenderness is probably the second most common. And usually the idea is, maybe you can decrease the dose if you have that. But again, usually it's something your body adjusts to. Bloating, nausea, vomiting, gas, constipation, that can be seen in some people with the oral estrogen, but not the transdermal estrogen. And then generally the initial mood swings are usually seen with the progesterone. So transdermal versus oral, again, we kind of talked about this, but the transdermal skips the first pass metabolism. That's why that's the liver metabolism, so it decreases the risk of blood clotting. It's kind of, in general, what we would prefer. And so there's no increased risk of blood clotting in the studies that have been shown with transdermal. Also a greater decrease of triglycerides. But the oral, potentially there's a greater decrease of diabetes and a greater reduction in colon cancer risk. So, it's something that maybe for these reasons, maybe you do decide to do oral, and that's fine too. So comparing them a little bit increased side effects of the oral, more GI side effects, more drug interactions, obviously. And then the dosing would be daily as opposed to weekly. So transdermal is a little bit easier in that regard. The only other benefit of oral, I would say, would be the cost. So the cost is cheaper. So it's about $10 to $30 in the 90-day period, as opposed to transdermal is about $30 to $60 a month, and progesterone about $20 to $50 a month. So we're kind of thinking maybe $100, but mostly insurance will cover it. So there you go. You guys might have heard about non-compounded versus compounded. So compounded hormone replacement therapy is something that's not FDA regulated. So the FDA regulates all the non-compounded hormone replacement therapy. It's rigorously tested, whereas the compounded, it's compounded by a pharmacy. And the reason that they do it is, in general, so that they can kind of really titrate it, very specifically for each person. Whereas there's, going to be somewhat limitations of dosages that are FDA approved. But overall, it's probably worth it to go with the FDA approved hormone replacement therapy because it's, there's less risk of inconsistent dosing, contamination, things like that. Usually the compounded, they label it as bioidentical. Really, what is prescribed, and FDA approved, most of them are bioidentical. The transdermal, the micronized progesterone, are and oral estrogen are usually bioidentical. There are some synthetic options, of course, as well. But in general, they'll hook you in with the idea that this is more natural. It's all the same, other than increased risk of contamination. They often come in pellets as well, which potentially that could be beneficial for some people, right? You take them for 3 months and then you don't have to deal with it as much, whereas you weekly change a patch. But the issue with that is that you can't remove them if it's causing issues, right? So yeah, that was it. Bone health is part of the upcoming series. Dr. Andrew Moran's going to do that. Cardiovascular health, and then menopause by Dr. Greta and Katie at Public Court. So yeah, if you have more specific questions, we'd love to follow up with you too, and you can make an appointment. We can kind of discuss how this might make sense for you guys. And yeah, these are some other kind of books that can be really helpful in understanding a little deeper. Any other questions?
How long do people usually stay on it once you go on it?
Yeah. So in general, it depends. So like I kind of said with the osteoporosis, it's probably something that you could just kind of take indefinitely. But in general, people will say, okay, we could, if it's just for the vasomotor symptoms, I think there's enough benefit outside of the vasomotor symptoms that it's probably worth it to stay on it longer term. But for the vasomotor symptoms, it's usually something, as we said, they last 7 to 10 years on average. So you can kind of, if you want to try coming off at 5 or 10 or 15 or whatever. So usually it's about that probably in a typical modern medicine clinic, they would say, let's try to wean you off and see how you're doing after 5 years, because there's still a lot of that concern and the feeling emotion behind it of the risk. So.